Hello everyone, welcome to another USMLE case presentation on the cardiovascular system. Today we'll be looking at the interesting case on cardiovascular pathology. I'm Dr. Wahid Mohabir. I'm a PGY2 resident in Miami, Florida. I've taken the STEPS exam and you could use this video to aid in preparation of your exams. Alright, so we have here the case of the hypertensive teenager. So let's look at a vignette. A 15-year-old boy is brought to the pediatrician for a routine sports physical. He has no significant past medical history, although he mentions getting frequent headaches and occasional nosebleeds after running. He denies chest pain or shortness of breath. On physical examination, he appears well developed. His vitals revealed a blood pressure of 150/92 in the right arm and a heart rate of 78 beats per minute. The physician notes that the patient's femoral pulses are palpable but weak and delayed compared to the radial pulses. On auscultation, a systolic ejection click is heard, followed by a systolic murmur, best audible over the left interscapular area of the back. A chest X-ray is ordered and shown. Alright, so this is a chest X-ray. So take some time to look at this and look at the finding there. So let's look at our question. Which of the following additional findings is most likely to be present in this patient? Fixed splitting of the second heart song or S2, cyanosis of the lower extremities but normal upper extremities, systolic blood pressure in the left leg of 110/70, a crescendo-decrescendo systolic murmur radiating to the carotids, or a displaced point of maximal impulse to the right. So you could take some time, pause this video, and lock in your answer. Alright, and the correct answer is C, systolic blood pressure in the left leg of 110/70. Alright, so the patient in our case had the coarctation of the aorta. So what's that? It's a narrowing of the aorta, typically located just distal to the origin of the left subclavian artery at the ligamentum arteriosum. This narrowing creates a mechanical obstruction to blood flow coming from the heart. So proximal to that obstruction, and you'll see a picture on the next slide, the heart pumps against high resistance, leading to upper extremity hypertension. So when this happens, patients would experience symptoms like headaches and epistaxis, and that's what was seen in our patient. Now, distal to the obstruction, um, blood flow is restricted, leading to lower extremity hypotension and weak pulses. So that's why that was the answer to our question. Alright, so this is visually representing coarctation of the aorta. As you can see here, this is the narrowing at the aorta. So proximal to this narrowing here, you can see um, there would be high pressures in this area, and that would cause uh, hypertension of the upper extremity. Uh, Distal to the obstruction, here you would see that there would be relatively low pressures going to the lower extremity, causing lower extremity hypotension. Alright, so other clues in the case that pointed towards coarctation is what is known as the radiofemoral delay. So basically what this is if you palpate the patient's radial pulse and femoral pulse simultaneously, you're going to feel the radial pulse coming before the femoral pulse. Normally they should be equal, but that radiofemoral delay means that it takes longer for the pressure wave to push past the narrow aorta to the legs than it does to reach the arms. Also, another finding that we saw in the case is the interscapular murmur. The turbulent flow through the descending aorta is best heard on the back between the shoulder blades, and this is something very specific to coarctation of the aorta. Another finding that you saw on the chest X-ray is what is known as rib notching. So what happens here is over time, the body develops collateral circulation via the intercostal arteries to bypass the blockage that is at the level of the coarctation, just in an effort for the lower body to receive more volume. So these dilated arteries erode the bottom of the ribs, and it's seen on the chest X-ray, as you could see here. So the arrows are pointing towards the lower aspect of the ribs, and you could see the bony erosions here. And that's just because the neurovascular structures um, runs below the ribs. And as this artery dilates, it compresses the bone, and that causes the erosion of the bone. All right, so now let's discuss the incorrect answers. Uh, A is incorrect, fixed splitting of S2. This is usually due to atrial septal defect. B, cyanosis of this was the biggest distractor in this case. This is incorrect, cyanosis of the lower extremities or differential cyanosis. This is seen in PDA, and usually not only with PDA, when there's also coexisting reversal of shunt, which is known as the Eisenmenger syndrome. Uh, that's when right to left shunt occurs and the deoxygenated blood from the right side goes to the left side, and that causes the legs to become more preferentially cyanosed. So this is seen in PDA and not in coarctation. Coarctation, you would have a pressure difference, uh, and in a PDA with Eisenmenger syndrome, you would have a blood oxygenation problem. All right, so D is incorrect because a murmur radiating to the carotid would point toward the aortic stenosis. But usually, while a coarctation does usually have a bicuspid aortic valve, which could produce a murmur radiating to the carotids, in our patient, that wasn't described. The murmur that was described was the one um, in the back and not radiating to the neck. Displays PMI to the right. In coarctation, you may have some left ventricular hypertrophy, which may display the PMI to the left instead of the right. So this is incorrect. All right, so now let's review the high yield points in that case and for coarctation of the aorta. Usually in patients with coarctation of the aorta, you may see a bicuspid aortic valve too. Usually coarctation is associated with a Turner syndrome. It's actually the most common cardiac defect in patients with Turner syndrome. In patients with coarctation, you might also see Berry aneurysms. So look out for patients coming in with the worst headache of my life, which could indicate rupture of a Berry aneurysm causing a subarachnoid bleed. And look at the X-ray, look for rib notching. And in the X-ray also, you could also see what is known as a tree sign, indentation of the aorta at the site of the coarctation with pre and post stenotic dilation. Alright, so this is what a tree sign looks like in a patient with coarctation of the aorta with the pre and the post stenotic dilation, creating like a sort of tree here, as you can see. Um, and this is what is known as a tree sign. Alright, so this is the end of the case presentation. If you like this content, give me a thumbs up. If you want to see more contents like this, please subscribe to my channel, and I'll see you in the next video. Bye bye.